Hello, everyone. Welcome to our grand rounds. We have a special speaker who's one of us, Dr. Stephen Thielke, who has actually been wonderful and filled in for us for an absent speaker. Stephen attended medical school, psychiatry residency, fellowship in geriatric psychiatry, and a T32 fellowship in geriatric mental health services research at the University of Washington. He works in the Geriatric Research, Education, and Clinical Center of the Puget Sound VA, where he is the Associate Director of Education and Evaluation. He is an assistant professor in our department. He is currently supported by a K-23 Beeson Career Development Award to investigate shared decision-making and predictive modeling for geriatric depression. He has published research about longitudinal data analysis, geriatric depression, predictive modeling, chronic pain, and technologies for aging. From 2010 to 2011, he was president of the Washington State Psychiatric Association. Dr. Thielke.
Thanks, Sharon. It's a real treat to be here. So this is my first appearance here in Grand Rounds, and I was reflecting on prior Grand Rounds I had seen and looking for inspiration, and thought back to Murray Raskin's talk about 10 years ago about prazosin. I don't know if any of you remember that, but if you left that talk and you weren't ready to prescribe prazosin to just about everybody and take it yourself, then there's something wrong with you. Unfortunately, in my quest to be inspiring, I think the wires got crossed a little bit, and my talk is in fact more about things that don't work. And I hope it doesn't come across as a downer, and I'd really like to convince you today that it's important to recognize both the problems that we're faced with as well as the opportunities that exist in the treatment of dementia. So I don't have any conflicts, and in fact I think, as you'll see, there's really but by no means anyone who would pay me to say any of the stuff that I'm going to talk about. So what I wanted to do today, first of all, to tell you what I'm not going to talk about. I'm not going to present a general explanation of what dementia is or how to diagnose it. I assume that all of you have plenty of clinical experience with the disease. And if I say something that doesn't make sense, please feel free to interrupt. Secondly, I am going to concentrate on the problems, and that doesn't mean that there haven't been plenty of advances in dementia care. There's going to be a lecture in the fall, I believe, by Sue Borson, talking about her 4-part model for dementia care that's really an outstanding approach to dementia. That's a great advance, and I can look forward to that as a case of someone talking about what does work well for dementia. And then third, I'm not going to talk about all the problems there are for dementia now. I picked the ones that I thought would be most timely and useful and interesting to you, but there certainly are plenty of others, including the economic burden that the disease is having on Medicare, and also antipsychotic use. So there's plenty of other areas, and I don't want this to seem like it's the only or even the most important challenges, but I think these are ones that are important for you to know about. So what I wanted to do today is, first of all, look back at some of the history of Alzheimer's disease and other dementias. Oops. There we go. Then to talk about a new diagnostic imaging agent, Amivid, that just got approved a couple months ago. You may not have heard much about. Talk about some of the problems with medications, both for treatment of Alzheimer's and also some of their side effects. Then to focus a little bit on prevention and where we are in terms of understanding what works for preventing Alzheimer's. And then this one is kind of a teaser and out of left field, but I want to come back to a core philosophical point about what we do with dementia and how we use evidence to make clinical decisions. So let's go over a little bit of the history. And here, let me quiz you here. This was the only psychiatrist ever to win the Nobel Prize for clinical work. There have been other psychiatrists who won for basic sciences research, but this is the only guy ever to win the prize for the advancement of clinical science. Anybody recognize him? This guy's name is Julius Wagner Joreg, who worked in the early part of the 1900s, and he received the award for curing what was at that time the most common form of dementia. This disease, which was known as paralytic dementia, or sometimes known as general paresis of the insane, filled up the sanatorium. Something like 15% of the people in institutional care at that time had this disease, paralytic dementia. Does anybody know what disease that is? The slide kind of gives it away at the bottom. Yeah, neurosyphilis. So 100 years ago, the problem was not what we now call Alzheimer's disease. It was instead an infectious disease, neurosyphilis, that was running rampant. And Wagner Joreg figured out that you could cure neurosyphilis. And his treatment was somewhat unexpected. Does anybody know what he did? Matt, all right.
I think he gave them malaria.
He gives them malaria, exactly. So what you see in this picture, the little guy sitting in the back who's frowning is a patient who has malaria, and his blood is being transfused into the guy sitting down in front who's got paralytic dementia. And that guy then will have high fevers, go through fits and convulsions, and in about 40% of the cases it was a cure. About 10 to 15% of the patients died, but that was considered to be an adequate risk. So that was Wagner Joreg's contribution. As a guy, he was really something of a bully and an awful person. He ended up being a proponent of the Nazis and was really in favor of forced castration for people whom he considered to be inferior. So as a person, he really was not what we would consider to be a model of a good psychiatrist. So does anybody recognize this guy? Surprising that his face doesn't have more broad recognition. This is Alzheimer. This is Alois Alzheimer, who began his work on paralytic dementia. That was the field that he initially worked on, and he wrote his main thesis about neurosyphilis. And in the process of caring for patients, he ran across the woman on the right, whose name was Auguste Dieter, who at the age of 51 started to develop significant cognitive impairments and memory problems that were very different than neurosyphilis, and she didn't have any of the other stigmata of the disease. So Alzheimer recognized that she had something different going on and was fascinated in her case, and when she died 5 years later, he performed an autopsy that found what's shown there and what he called a peculiar material in her brain. And this material and the patients who had these symptoms fascinated him, and through the next 10 years of his career before his untimely death at the age of 50, he really characterized well how people while they were alive had symptoms that we now know are characteristic of Alzheimer's disease, and they also had plaques and tangles in their brain. I couldn't pass this one up. This is picture of Alzheimer and his research group in Frankfurt about 1909. Alzheimer's the guy in the white coat and the little mustache. And there are two other interesting figures here, and I think it's great they're together. The guy on the right, anybody happen to recognize him? If you get these, you get super stellar points. This is Lewy, of Lewy body dementia. He was Friedrich Heinrich Lewy, who was from Germany, and he ended up moving to the United States before World War II, where he changed his name to Frederick Henry Lewy, spelled Lewey, which was kind of funny that you get a disease named after you and then you change the spelling of your own name. But he did really pioneering work in neuropathology, and a lot of his work was also in neurosyphilis. And then this guy here, anybody recognize him? This is Ugo Cerletti. Anybody know what he invented? ECT. Yep. So he is the founder of ECT, and his inspiration for ECT, to continue this theme, was Wagner Joreg's treatment of patients with malaria. He thought, hey, maybe we can use another approach to give these people fits and seizures and cure their diseases. So this theme of neurosyphilis really perfuses all of the work in this time. And I wanted to mention this other psychiatrist because he really goes under-recognized, and his work was quite important to the developments in understanding Alzheimer's at the time. Anybody recognize him? This is Solomon Carter Fuller, who was a pioneering African-American psychiatrist. His grandparents were American slaves who were freed and returned to Liberia in West Africa, where he grew up, and he came to America to attend medical school. He suffered terrible discrimination his whole life, earned about half the salary of his counterparts, but he persisted and did some incredibly pioneering work, including working with Alzheimer's for a period of several years. And his introduction to Alzheimer's lab was the use of photomicrographs, so taking a picture through the microscope so you get something that really looks like brain tissue and you can figure out what's going on, instead of Alzheimer's picture, which looks like a bunch of squiggles. So he really made seminal contributions to the field, and also was renowned at the time for his diagnostic and clinical skills dealing with patients with paralytic dementia or neurosyphilis. So through all of these figures at the early part of the history of dementia, there's this theme that I'd like to return to again. And when you read their work, you appreciate that their understanding of science was based on a pretty straightforward approach, which is that you figure out what the disease is, you figure out some treatment options for it, and then once you figure out what the available treatments are and what the best ones are, you go out and you cure the disease. So the model of paralytic dementia, neurosyphilis, is pretty clear. It's identified as an infection. You can see the spirochetes. You know it's syphilis. You figure out a cure for it, which is to induce a fever using malaria, and then you give, I forgot to mention that these people were given quinine afterwards, so the malaria went away. And then the right thing to do is to attempt a cure for everyone. And this really was the predominant model, and the one I think that Alzheimer was starting from. So the question that we're going to come back to repeatedly here is, we identify there's this peculiar material in the cortex of patients with Alzheimer's disease. What can we do about it, and what's the right thing to do about it? And as we'll see, it's much more challenging than anyone ever would have thought at first glance. So before going into some of the current challenges, I wanted to present a little bit of background about the population burden of dementia. When I give lectures to the medical students, I ask, what's the biggest risk factor for dementia? And sometimes, you have to think about it a little bit, and sometimes people say, well, ApoE, genetics, or some kind of risk factor. And it's so obvious that it almost doesn't bear stating. It's age. So the older you are, the more likely you are to get dementia. And when people die before about age 60, the prevalence of dementia is going to be very low, which is why Alzheimer's work was brilliant in a way, because he picked out these cases and then correlated them with neuropathological findings. Nowadays, there are so many cases of Alzheimer's disease that it really has become something that you almost can't turn around without seeing. But I'm going to resort back to this concept of the increase in dementia at increasing ages several times. So on the left shows some real population data based on 6 different studies from around the world. You can see there are similar trends based on age group. And then if you condense this into a mathematical formula, you get what's on top there. That's known as the Brookmeyer equation for describing the incidence of dementia. So if you calculate the incidence, add up the yearly incidence, you get the prevalence, which is shown on the right graph. It's not exactly the same because it doesn't account for death, but it's roughly the same. So basically, at about age 65, 1% of the population has dementia, and that goes up considerably. And this is important for thinking about what we do for people who are relatively young. So first I want to talk about this new imaging agent. And Alzheimer's is very easy to recognize in brain tissue. You've got the plaques and the tangles. They're depicted in a cartoonish format there. But how do you identify it in living individuals? And this is a little bit harder. So Ronald Reagan and Margaret Thatcher both suffered from Alzheimer's disease. And the question would be, if you've got somebody who's showing some symptoms, how can you know they've got Alzheimer's? Usually we use clinical diagnosis, but let's say that's not certain. So this is where you'd think that an agent that you could use to get pictures of someone's brain would be very handy for identifying Alzheimer's disease, because you don't have to do a brain biopsy. So just 2 months ago, this new drug, florbetapir F18, also known as Amivid, like amyloid video, was approved by the FDA. And I don't want to misstate what this drug is, so I'm just quoting exactly what they say on the package insert, that it's for PET imaging of the brain to estimate beta amyloid neuritic plaque density. So that is how much plaque there is of beta amyloid, which, if you remember, is the misfolded amyloid protein that agglutinates and forms plaques, in adult patients with cognitive impairment. So these are supposed to be people who have cognitive problems, who are being evaluated for Alzheimer's disease or other causes of cognitive decline. So off the bat, this is not for identifying just anybody who's got Alzheimer's. It's for estimating the neuritic plaque burden in people who have cognitive impairments. The limitations that are described are also important. So they stipulate here, and I'm sure they had their lawyers go over this carefully, that if you have what's considered a positive scan, that doesn't mean that you've got Alzheimer's disease or any other cognitive disorder, and also that this drug has not been evaluated for telling whether somebody is going to develop dementia or any other neurological problem, or for telling you if a treatment is working. So these are a lot of caveats off the bat about what this drug does and what it doesn't do, and I'm going to focus on one of the particular problems associated with it. When you look at the nitty-gritty about how good this medication is at diagnosing Alzheimer's disease, they took people who were in the end stages of Alzheimer's, were predicted to die relatively soon, and used the imaging agent with radiologist readers who were blinded to all the clinical information, and then correlated that after death with brain biopsies, or rather autopsies. And the sensitivity of the scan in vivo for diagnosing Alzheimer's to correlate with a post-mortem diagnosis was 92% for readers who had an intensive in-person training, and the specificity was 95%. And for readers, the radiologists who got an online training to learn the same material, the sensitivity was a little bit less, and the specificity was still 95%. So you look at this, you say, well, that's pretty good. More than 9 in 10 of the cases are being diagnosed accurately, and there's not that many errors involved, so this is a great idea. Unfortunately, if you think back to your basic epidemiology, you remember that the sensitivity and specificity are really just properties of the test. They don't tell you the consequences of the test or what it means when you apply it to a large group of people. And the more important thing that you'd want to know is the positive predictive value. So remember how this one works? So the positive predictive value is the number of true positive cases divided by the number of total positives that are given by the test. Or basically what it means is if you get a positive test, what's the likelihood that you do have the disease? It's strongly dependent on prevalence. So another way to reframe that equation is, as you see below, it's sensitivity times prevalence divided by sensitivity times prevalence plus 1 minus specificity times 1 minus prevalence. And you'll notice that as prevalence gets lower, the positive predictive value also gets quite a bit lower. So for this new imaging agent, when you figure out what the positive and negative predictive values are based on population estimates, so this is using the Brookmeyer equation for the prevalence of the disease at different age groups. So the x-axis is age, and then the y-axis, the red bar, is the negative predictive value. That's the likelihood of not having the disease if you get a negative test. And the blue or gray scale is the positive predictive value, which is the likelihood of having the disease if you get a positive test. So what you see here is that if you went out and gave this test to a bunch of people over aged 50, your likelihood of if you have a positive test, of picking out people with real disease is really pretty low. So if you're 75 years old and you get a positive test, your chance of having the disease is still 50%, which is just bizarre. I have to recheck the numbers every time I do this calculation because it just doesn't seem to make sense. But it really shows how the prevalence of a disease strongly determines how likely you are to have it, regardless of how good the test is. So the challenge you can see here is that if you're going to apply this test to people who are unlikely to have the disease, when you get a positive result, what are you going to do? Are you going to tell the person, well, you have this disease, and you'll be wrong a lot of the time? Or do you tell them, we don't know, come back and do another test, and then you get another equivocal result? Or do you tell them you've got a 50% chance of having the disease, go away? It's a real dilemma that doesn't really make it easier to diagnose people or to tell them what they should do with the information that you're giving them. The negative predictive value is quite high because the population prevalence of the disease is really low, as you might expect. So that's not really the challenge. But the problem with the positive predictive value really is a big one, and I think that's the reason why they have all the disclaimers on the advertising for this new imaging agent, that it's not a way to identify the disease in people who are asymptomatic. So it would be great economically for the company that makes it if it could be used as a screening product, but you really only have to think through what the meaning of a positive test is in different populations to realize that would be kind of a public health disaster, because you'd get a bunch of people who are walking around thinking, oh boy, I've got Alzheimer's, what am I going to do? The other part of the context is to remember that Alzheimer's is just one type of dementia, and there are plenty of other forms that do not involve beta amyloid neuritic plaque burden. So this was a study that Mayo did. It wasn't a big one, but it's nicely representative of the types of autopsy findings that occur in dementia. These were 89 patients who had well-established dementia during life, and then on autopsy, about half the subjects had only plaques and tangles, and then 12% had both plaques and tangles and vascular changes. Other studies have questioned this because their dividing line for vascular changes really was pretty far on the right for excluding vascular changes. There's other work that suggests that vascular disease really is much more common in Alzheimer's disease. But anyways, when you look at the other causes, there were 13% of people who had no plaques and tangles, but only vascular changes. So they were cases of dementia. 8% there had other forms of pathology that weren't vascular and also no plaques and tangles. And 4% of people didn't have really any findings on their autopsy. So you wonder what was up with them, because their brains looked totally fine, and yet they had what sure looked like a clear clinical dementia syndrome in life. So the problem here is that if you scanned all these people, you would end up with about 1/4 or 1/5 of them who seem to have normal brains. And you're then left trying to figure out what to tell them. You tell them, well, you don't have Alzheimer's disease, but you may well have another condition. And what does that add to their life, their quality of life, and their expectation for the future? And likewise, if you get a positive test on someone and you tell them, well, you may have Alzheimer's disease, but the chances are that you don't have it either, and we can't predict. It's really extremely complicated to take this information and to turn it into something that's straightforward and clinically useful. So does that make sense as kind of the basic challenge of being able to image people? The premise is fantastic, and it would be wonderful to know exactly what's going on in people's brains while they're alive, but the downside of it is that lacking perfect information, and even if you do have perfect information, sometimes that added value only complicates rather than clarifies a clinical decision. So I want to turn now to some of the treatments for dementia and tell two stories, one about a potential drug for Alzheimer's, and then the other about a risk of the existing medications. So there are literally hundreds of drugs under investigation for Alzheimer's. As you might imagine, given the huge population burden, it's an important area to be worked on, and if we had a cure for it, it would be fantastic. The drugs that we have are typically assumed to be quite safe, and certainly when I was learning about them in residency and fellowship, it was taught, well, they may not fix the problem, but really they're a low-risk medication, and they're worth a try for that reason. They have some side effects, but they don't have any significant problems. And I'm going to address two facets of this that I think are important for you to know about. The story about the investigational drug is about Dimebon. Has anybody heard of this one? I was hoping all of you didn't read the Alzheimer's press in your spare time. I think this mainly went under the radar, but it's a fascinating story. So there's this antihistamine, latropyridine, that had been used in Russia for decades, sold over the counter, really no significant risks ever associated with it. And people started looking into it as a treatment for neural degeneration. And when they looked at animal models, it seemed to enhance cognition and to inhibit cell death, like this incredible cure for the neurons dying. And in Russia, they did a multi-site placebo-controlled trial of 183 patients. And the results of this were staggering. The people who were on the active drug showed improvements in all sorts of domains, not only cognition but also functioning and behaviors. At 6 months, they improved by about 2 points on the ADAS-Cog, which is a moderate improvement, but at a year they had improved by 7 points, which was a huge difference. So this looked like a new blockbuster. This was going to be the thing for possibly not only halting the progression of Alzheimer's, but even for reversing its course, since these patients seem to be improving. And I remember getting little blurbs in my email announcements about this drug, and one of them in July 2008 was how Dimebon shines as an Alzheimer's therapy. So, as you may guess, this was promising for people who wanted to invest in this sort of treatment, and Pfizer made a massive investment in buying the worldwide rights to this drug, as well as funding a big study to demonstrate its efficacy. So they wanted it to be worldwide, not just limited to the U.S., so they enrolled 600 patients in 63 different sites across 3 continents. Unfortunately, their results were absolutely nil. No difference between drug and placebo at any of the time points. And in fact, it looked like the placebo group did a little bit better in cognitive outcomes. So this is very unfortunate, and it's hard to explain the incongruity between the earlier study and this one, but this is kind of what you're left with. When you do a careful, closely randomized, closely monitored study and you turn up no result, you kind of have to conclude that this drug did not, in fact, have any benefit over placebo. And the drug company ended up writing off $750 million, which they had invested in this. The last I checked, that's a lot of money. So when you look back on it, there are people who said, well, we told you so. And Samuel Gandhi, who works at Sinai and is involved in his own drug discovery, said that it was this drug that really never had a plausible mechanism of action. In fact, when some of the mouse models suggested that it increased amyloid levels, which wouldn't make sense for a drug that's supposed to treat Alzheimer's, and that it came out of this incomprehensible series of screens. So this drug is clearly a different approach scientifically than using malaria to treat neurosyphilis or giving people electroconvulsive shocks in order to fix general psychiatric problems. Unfortunately, those treatments which came out of left field seemed to work, whereas this one that was much more scientifically approached seemed to have no effect. So this is a real challenge that we're still faced with. And as I mentioned at the outset, there are a lot of other drugs that are being investigated, and there's promise in a lot of them. But unfortunately, this is the closest that we've come in the last couple of years to having a drug that might work, and it just doesn't work. So I wanted to address some other recent information about cholinesterase inhibitor donepezil, or Aricept, that may have escaped your notice unless you love to read the Archives of General Psychiatry front to back. This is a work that Chip Reynolds at Pittsburgh has done. And the premise of this study was to say, well, this drug donepezil helps some with cognition. Maybe it'll help with depression, too, in people either who do or don't have cognitive problems. So they decided to do a study where they would give people, older adults with depression, donepezil as a treatment, comparing it to placebo, with the idea that if you enhance cognition some, people will be able to engage in more meaningful activities, that they'll gain more insight, and that their mood will improve. Unfortunately, what they found was that the people in the treatment group, which is the non-dotted line and the figure, did worse in terms of depression relapse than the people who got placebo. So this one's also kind of hard to explain, but the difference was statistically significant for all the participants, and especially so for the ones in the bottom right who have mild cognitive impairment. So it looks like treating people with a cholinesterase inhibitor in fact increases their risk of depression relapse if they have mild cognitive problems. These patients did not have frank dementia, so it's hard to know what to do there, but you'd have to assume at least that you should be careful in treating people who have a history of depression or active depression with cholinesterase inhibitors, because it may end up having effects on their mood in the direction that you don't want. So this is, despite 100 years of work, it's still very challenging to know what the treatment options are for either curing dementia, which would be great, or even for managing its symptoms. So this is another area where there's a challenge ahead. So to step back a little bit, it would be ideal if we could prevent the disease in the first place. Clearly there's no silver bullet for fixing it. So maybe we could identify the factors that go into causing dementia and head them off at the pass and stop there from being such a big population burden of the disease. So the National Institute on Aging funded this consensus conference in early 2010. And to their credit, they did it in a very careful way. They pulled in experts in methodology and in the study of Alzheimer's, but didn't have anyone with a specific vested interest in any of the prevention strategies. So they really tried to be as unbiased as possible. And they looked into various lifestyle, genetic, and health-related risk factors. Their little logo shows the brain, see, and then there's the question mark. Do we know what's going on? The genes are on the bottom left, and there's the apple and the guy running, and a little crossword puzzle. So they kind of capture it all about what the factors might be. And these are all things that you'd think would help your brain to retain its capacities. Like you're exercising, you're doing crosswords, you're eating well. They've got to be things that are going to help you maintain your cognitive abilities as you get older. And if we could get people just off their butts to exercise and eat better, then we'd prevent a bunch of the disease. So let's look at what they really found. First, I'm going to discuss the risk factors and then talk about potential prevention approaches. So there's a lot of different types of factors they investigated. And I need to say that the fact they didn't find significant data doesn't mean that the results couldn't be there. It's that the studies haven't been done well, or well enough to say one way or another. Nutrition and dietary supplements. There's really no clear role for any of them as a risk factor, which is kind of surprising because you'd think there would have to be something. The medical factors as risk factors, we know hypertension is a risk factor, but diabetes didn't have quite as significant a role as was initially thought. And then there were other conditions like sleep apnea, traumatic brain injury, and obesity that did not stand out as significant or consistent risk factors. This one was somewhat surprising, that depression was really a very consistent predictor of risk of dementia. So this is kind of hard to explain, but there's clearly something correlating being depressed and the development of dementia and cognitive decline. So this was one that stood out well. It's not the same as treating depression as a way of treating dementia or preventing dementia, as we'll see, but this was clearly a risk factor. And then in terms of medications, you'd think there would be some kind of medication that would be associated with lower risk of dementia. And the studies have been done, and really, when you look carefully at the study, there is no consistent evidence on balance for any medication preventing dementia, or even being a significant risk factor, which is really surprising, I think. Socioeconomic factors are a big deal in most of the psychiatric conditions that we talk about. Certainly mood disorders, anxiety disorders, personality disorders have a strong link to childhood factors, but dementia really does not seem to be one of those conditions. For people's current level of engagement in society and what their life is like, that if your spouse dies, you're much more likely to develop dementia. And there's some evidence that if you're actively engaged in your world, you're less likely to develop dementia also. But that's a little hard to know what cause and effect are. In terms of exercise, which is always popular and seems to carry its own halo, there are some preliminary associations between being more active and preserving cognitive function. But here again, it's hard to tease out cause and effect, because if you're having cognitive decline, you're less likely to get out and exercise also. Smoking is a risk factor for current smoking, but past smoking didn't really stand out much. And then alcohol, which had been touted as a really good factor for preventing Alzheimer's, really didn't hold up in these meta-analyses. So what you can see is there's a mixed group of risk factors that have some moderate association with development of dementia, but none of them really stand out. And also, none of them are really strong enough to merit being used as prevention strategies. So when you look at the science around the prevention of the disease, you find that there is inadequate evidence for suggesting any intervention. And that's a pretty bold statement for a consensus panel to make. So to be even more blunt, there is no known medication that can said to be reliably delay the onset of Alzheimer's disease. Three drugs in particular have been adequately studied to say that they don't work. Those are vitamin E, which when I was a fellow we were still giving to everybody because we thought it worked. Ginkgo, which had been very popular because it's nutraceutical, but it does not work in placebo-controlled trials. And then the cholinesterase inhibitors, which don't work for preventing dementia. For the other types of interventions, like exercise and diet or staying active or doing crossword puzzles, there really hasn't been adequate study. So it's not to say they don't work, but the evidence is certainly not strong enough to say that they do work, nor is it strong enough to recommend that everybody go out and do any particular thing in order to prevent Alzheimer's. This conclusion of the panel's report is fascinating, I think, when you think about the 100 years of work that have been done for this disease. And you could read that on their own. But basically, they suggest that we don't even really have highly reliable criteria that we're dealing with, and that when criteria exist, they're not well applied across studies. And that basically we don't have adequate evidence to suggest anything one way or another, which seems like kind of a discouraging finding, but it certainly encourages doing more research and trying to figure out more what's going on. If you wanted a personal account to show the problems with prevention, I think this is a great case. Anybody recognize this guy? Not a medical person. Without him, we wouldn't be using the computer right here. This is Claude Shannon, who is the father of information technology, truly ahead of his time in understanding how computers could work, and wrote what's considered to be the most important master's thesis of all time, where he set forth pretty much all of information theory, and people ran with it. So you should do this. It is a good idea to treat someone with this medication. When you meet with a patient, you say, you should take this pill. That's a moral statement. And when he reasoned through it, he recognized that there's no way that you can get from facts to moral statements. That no amount of information is going to tell you what the right thing to do is. And the right thing to do is based on a whole different set of moral reasoning that most of us kind of have intuitively, but we don't talk about much. Like the rules for research, like respect for persons and autonomy. That facts won't tell you that you should have respect for persons. It's just something we should do about it is not impacted significantly, nor does it undermine our mission of caring for patients and families with Alzheimer's disease. That what we should do about treatment or screening or prevention is based more around understanding the individual patient and understanding where they're coming from than by trying to apply a cookie-cutter approach to everybody. There's two sayings that I think nicely bring this home. One is a cliche that Maria Shriver is using all the time, that when you've seen one case of Alzheimer's, you've seen one case of Alzheimer's. And the more patients I see, the more I really believe this is true. And I think Whitney's nodding her head, that it's not a disease that affects everyone the same way, and people's interests in treatment and how they want to live with the disease vary enormously. So you're not treating the disease, you're treating the patient. And that's what Osler reminds us of here, that our goal is not to treat disease, it's to treat individuals. And there are, in the context of the problems I brought up, there are specific questions that I think really we should be asking more of as we learn more about the potentials for treatment and diagnosis. Like for any individual that you're dealing with, what would an early diagnosis mean to them? Is it worth doing the test because they really want to know? Or is it better not to give them information that may lead them down a path that they don't want to go down? What would a false negative diagnosis mean? If you find somebody and you do a scan on them and say, well, it doesn't look like you've got amyloid burden, but they've got vascular dementia and they continue to decline, how would that affect their and their family's quality of life? Likewise, what would a false positive mean? As we saw, if you start screening people for Alzheimer's, you're going to end up with a lot of folks who are told, you've got amyloid burden in your brain, and a large percentage of them will not have the disease. So for your own life, let's say somebody told you, hey, guess what? You've got a disease that's going to kill you progressively over about 10 years. It's not like it's an easy answer. And certainly Huntington's disease, which is a model of that, where there's a specific test, has not led to any easy answers either. Similarly, around advice around lifestyle things. We don't really have strong scientific evidence, but there's plenty of other good reasons to recommend that people exercise or eat well. But that has to be tailored to the individual and where they're coming from. It's not like you'd want to go out and tell everybody do or don't do something because it's based on their experiences. And finally, really what we're dealing with in dementia care is quality of life for both the patient and their family, and trying to remember that that's the paramount good, and that really we use what we have in order to try to help people accomplish as much quality of life as possible and to minimize harms. But there again, it's not like a cookie-cutter approach is going to work, and that the way to understand the right thing to do is to listen to patients and their families and to figure out how to treat them individually. So to wrap up, I wanted to give you, this is Alzheimer's research motto. And it's a grand irony, I think, that his name is attached to a disease that has been so vexingly difficult to treat, when he clearly was such an optimistic guy about the promise of science. So he's saying that reservations and paralyzing despondency aren't going to help science advance, but what you need is a healthy optimism. And I think that's still true. Even though there may not be a lot of movement forward on some of these fronts, that really the key to being able to deal with Alzheimer's and possibly to treat it in the future is to remember that it is important to remain optimistic, even as there are pragmatic concerns about exactly how to do that. So I think Alzheimer's is still inspiring us, even 100 years on, and with a lot of dead ends that we've been down. So I would be happy to take any questions. And I'm told I'm supposed to turn on this? Okay. There are no questions from the remote site. Yeah?
Can you clarify the relationship, the temporal relationship between depression and dementia?
So that's a fascinating question. The question was about the temporal relationship between depression and dementia. And that really is a problem of when you start measuring. So the studies have considered pretty much every combination that you could look at. So previous life history of depression, but no current symptoms. When you track people, age 65 and on for a period of 10 years, earlier life depression increases risk of dementia, even if you don't have current depression. Similarly, current depression increases risk of developing dementia simultaneously. The risk increases the more current symptoms there are and the closer you get to it, but it seems like even having some episodes of depression earlier in life would increase your risk. And then the question of dementia and the development of depression is a little bit trickier because it's somewhat harder to diagnose, but that also seems to, having an onset of dementia also seems to increase the risk of developing depression. So it's hard to explain exactly how those would be correlated on a neurochemical basis because our model of depression is neurotransmitters, and that you've got some kind of neurotransmitter deficit or excess and that we can fix it. Whereas the model of dementia is that it's a progressive neurodegenerative disease with cell death. And it's hard to get from neurotransmitters to cell death, and we're still really sorting that out. But that's a really great question. Yeah, Marty.
Have you tried giving them malaria?
Malaria. Maybe that could be your future, Marty. Yeah. Well, the quest for a silver bullet is still very enticing, and that's why Dimebon, took off so much, and why somebody invested $750 million in it, because it would be wonderful if you had a fix, but it sure hasn't come out yet. Yeah, Mark.
Can you speak about what happens if you start combining things? I'm of the mind that a lot of the peer studies look at single things, but it really may be that it's a combination of the way we diagnose and a combination of treatment that really might be the answer, rather than thinking there is a single way to screen and a single way to diagnose and a single way to treat.
That's a great question. So Mark's question is about taking a combination approach. And I think that really is what I was trying to get at with the explanation of where we should go and what the right thing to do is. That the attempting to study the disease in slices clearly hasn't found any one cause. But it's likely to be a multifactorial disease that also has effects across different domains of life. Not only the brain, but the person's social role and functioning, and their role in their family's role in their life. And that prevention, similarly, is not something that if you get people to jog 2 miles a day or eat fish more, they're going to avoid dementia, but that as a lifestyle factor, there may be effects. So what I think you nicely articulated what I'm suggesting is the better approach, which is to look at this person as a whole, to see them as an individual, and to think about all the factors that play into their experience of the disease and their potential risk factors, and to try to maximize their quality of life as much as possible. Hey. Oh yeah, Whitney.
The slide where you had the 86 people with a pie graph of the different kinds of
Mm-hmm.
dementia, were those people that were clinically diagnosed with Alzheimer's or any?
No, that was right.
So they were trying to figure out. Okay.
Yeah. So the differentiation between Alzheimer's and vascular dementia, especially, can be tricky because in life, as you know, people can look quite similar. The whole idea that vascular dementia involves this stepwise decline and that you have little strokes just hasn't held up. We know it's much more of a microvascular disease that has the same kind of necessary downward slope, and it's kind of an autocatalytic process after a while. So these weren't people who had a specific diagnosis of Alzheimer's, but none of them were necessarily categorized elsewhere. Like the 4 people whose brains seem to look normal are really hard to say what was going on, because in life, like clinically, they looked like pretty classic cases of Alzheimer's disease. Yeah.
My experience with things Soviet and Russian has led me to believe that science that comes out of the former Soviet Union or current Russia is frankly often bogus. And I'm wondering if you have any thoughts about this study you showed a few minutes ago, or any other scientific things that have come from Russia?
Great question. So the question is about science that comes out of Russia. And so I was fascinated by this, initial study that looked so good, and then the big follow-up that seemed to show nothing. And sure enough, the going opinion is that the first one must have been fudged in some way. I mean, there's no way you're going to get those kind of results by having some kind of patient selection, or to say that the drug just happened to work the first time and didn't work the second time. And the follow-up is, and there were this study and this study and this study that all showed the same effect, whereas a relatively large study was done in the former Soviet Union, and then when they tried to do a follow-up anywhere else in the world, the results were pretty much different. So it's not like this is the only case of that. And I think it just argues for reading carefully how the study was performed, and for making sure that we use as careful methods as possible. Yeah, I mentioned Cerletti, the guy who developed ECT. His big idea was not giving ECT to patients; it was giving ECT to pigs, and then taking the electroconvulsed pig brains and injecting that substance into patients, because he thought it would kind of condense the powers, the life force that was going on. And his first case reports of this were fantastic successes. I mean, he really thought that. There you go. Priming the pump. That's a great point. So if you're curious, you really only have to open the cover of the book about Alzheimer's disease treatments to find this theme again and again, of a treatment that may seem to work fantastically up front, and then when it's looked into in more detail just doesn't hold up. Well, thanks very much.